It's a two-stroke engine,
Yeah,
and it produces a hell of a lot of
pollution. Yeah.
soot.
Okay. Well, let's look at the extensor tendons and extensor mechanism and tendons of the knee now. Let's see. Why don't we start with a little case here? What do you think of this particular case, Tayson?
We have developmental dysplasia of the hips. I don't know.
You got these little things here. Either side, maybe a little shape of the proximal femora here. Looks like it's maybe a little coxavalga.
Mm-hmm.
And the bone age, 4-year-old bone age is a little bit abnormal here.
What do you say in the iliac crest?
Yeah, I didn't even see the things that were missing.
Pardon?
What'd you say? I'm sorry.
Yeah, what do you see in the iliac crest?
I guess they're iliac horns.
Doesn't
Yeah,
ring any bells, I take it.
No.
Okay.
And besides that, if you look at the anterior superior spine areas, you see an extension of the iliacs. Yeah, bilaterally, that's right, and that's abnormal.
Okay, and then here are just x-rays over the years. This is just showing delayed ossification of the patella. And this is called the nail-patellar syndrome or the Turner-Fong syndrome. So it's autosomal dominant. So there are a number of different dysplasias like that, but when you see funny-looking bones, you can kind of look it up.
Mm-hmm.
Okay, so let's start here. Okay. Snapping pain laterally. Yeah, different coronal cuts here of the lateral compartment. That's our lateral collateral ligament. Okay, lateral collateral ligament. Axial images here.
Mm-hmm.
Is it collateral ligament or something else?
I wonder. Lateral ligament here.
Oh, I
here
see.
We have.
Yeah, is that the biceps tendon?
That's the biceps tendon there.
Yeah. So fenestrated.
It's coming over here.
Well, is it displaced medially? Is that?
And then back here, so here's the biceps tendon coming down. So actually, this is an anomalous tibial insertion of the biceps tendon.
Okay.
Okay. Stuff you see every day.
This is a 42-year-old female with, again, lateral snapping pain. Are we seeing again that tibial insertion of the
so here's
biceps
the biceps
tendon
coming down, and it should attach to the fibular head next to the lateral ligament. But here we can see it's attaching over on the tibia, coming down and attaching on the tibia.
What do you think about the iliotibial tract?
And here it's attaching there. Iliotibial tract. Let me go back.
Yes.
I don't. And I think we're not quite lateral enough to see that on the sagittal images, and you really need a coronal, I think, to evaluate it well. Here we're too posterior. Well, there's one component that attaches posterior, but the main one attaches anterior.
Because usually that's what snaps over the condyle of the femur.
Yeah, that's more anterior. Right. right?
Yeah,
So,
okay.
so this is another anomalous. It's cord-like band of the biceps, but it's also attaching anomalously onto the to the tibia. Robert.
All right, here it looks like the LCL and biceps femurs are probably torn and mid-substance there.
After very California type injury, I guess here.
Being drugged by a wave.
Biceps tender. Okay, here we see anterior, posterior. Here's the fibular head, and here we can see the biceps and the lateral collateral ligaments coming down here, and the tears. Good. Okay.
All right. Osteoid, evaluate for osteoid osteoma. I think we might have a chronic traction lesion in the
Okay.
proximal tibia.
So that's where they're concerned about, but you don't really see a nidus,
Yeah,
and that's right where the
distal portion.
medial collateral ligament attaches to the tibia, and that's there's a popliteus right next to it, and that's a traction region of the medial collateral ligament and popliteus origins. They're both at the similar location.
Of a tugboat.
Yep.
Okay, I'm seeing, looking at the popliteus muscle, I'm seeing some edema there maybe within the muscle fibers.
Good. And here we see yeah, so these popliteus injuries are not that rare, and if you don't look for it, it's very easy to miss. So just remember to look at the popliteus muscle, especially if they have posterior knee pain. But in general, it's when you have sports injuries to the knee, this is one of the more common muscle tears, and it's easily missed.
They were rare before we got MRIs.
Yeah.
This is lateral knee pain after a twisting injury. Oh, it looks like that would be the proximal popliteus, the origin of the popliteus.
The insertion of the popliteus tendon. Right. Yeah, that's funny. It inserts proximally. It originates distally, where you have a muscle attachment to the bone, and then proximally you have turns into a tendon with a tendon attachment to the lateral epicondyle, and so you can see a lot of signal intensity within that popliteus tendon. So that's a grade 2 strain of the popliteus tendon. Robert.
All right, let's see. See some edema. I think that's over the lateral at the insertion of the popliteus tendon there. So I
Right.
think that's torn in.
So here we kind of see an avulsion injury to the bone at the popliteus insertion. There's the popliteus tendon. Here's the edema in the bone. And here you can see there's no bony avulsion fracture at the popliteus insertion. Okay. Tayson.
All right, I don't see any tendon at the insertion of the popliteus.
Okay. There's the stir sequence.
All right, looks like it is torn and
So there's a
displaced.
lot of tendinopathy with increased signal intensity, and here it's completely torn and displaced off the bone, right?
Yeah.
And you can see the T2 weighted image, again, these kind of injuries, the tendon stays pretty black, the fluid is very bright, so you can actually see the separation here very nicely on the T2 weighted image. The better contrast that you see for some acute injuries on the non-fat suppressed T2. And
That's a lot of fluid there too, isn't there, John?
it is. That's right. And you can see there's a lot of edema out here too. This patient had posterior lateral corner injury.
Okay. Again, looking at the popliteus hiatus, we're seeing some edema there. Um, yeah, there's some fluid. Maybe I'm not seeing a distinct tendon there.
Yeah.
Okay, the tendon's there. There's some edema in there, maybe tendinosis.
Yeah, probably a partial tear.
Okay.
There you can see the tear within the tendon.
37-year-old male cyclist with concern for lateral meniscal tear. Looks like, again, we see a bunch of edema along that lateral knee, and then I feel like there's a little edema in that popliteus tendon, but that's not where that is.
So what's this?
It's the iliotibial band.
Yeah, so that's the iliotibial band. This is the iliotibial band. This is edema around it. Here we can see edema around the iliotibial band. The next cut anterior would show the attachment of the iliotibial band main component to the tibial plateau. Notice there's a traction cyst here in the tibial plateau adjacent to where the iliotibial band attaches. And we see fluid here. Then you look on the axial image to see whether this is joint fluid or not. And what you can see, we're really posterior to where the suprapatellar pouch would be. So this is all edema in the soft tissues around the iliotibial band. And that's what the acute iliotibial band syndrome is like. And they get pain laterally here, often a sense of popping because of the inflammation. And it catches on the edematous soft tissues here, typically seen in bicyclists and long-distance runners. Robert.
All right. So it looks like I think that's an IT band. Looks thickened distally, and there's some fluid deep to it.
Fluid deep to it here.
Maybe like a chronic IT band, or maybe a bursitis.
Here are the axial images. And it turns out if you look through here, this fluid collection is not part of the anterior joint space, marked thickening of the tissues around it. And this is chronic iliotibial band syndrome. The first one was acute, and this is more chronic.
I would say that this is probably the most common problem that you've shown so far.
Really? I don't think it's safe.
I think that the friction of the iliotibial band is probably the most common.
Okay.
I don't know what your findings are, but in my experience, that's what I've seen.
Yeah, I don't see the popliteal tendon injuries that frequently. I also don't see iliotibial band that frequently either. But you may be right that the iliotibial band may be more common and certainly better known.
And in my experience has been pre and post MRI, so
Right.
that's the situation that I'm in. We didn't see or diagnose the popliteal situation.
Right. Okay, Elior.
We let a tincture of time take care of it.
Yep.
And rest.
So here we're looking at the IT band. I think, yeah, the finding here is this just deep to it. There's, yeah, this fluid collection, maybe a bursa.
Yeah, this is I think these are T1 weighted coronal images. It's not really quite as dark as you'd expect, just fluid. Here's a T2 axial.
Okay, so on the
So
T2,
this is fluid.
right,
So this is really a different signal intensity than fluid.
right. I mean, it has the same intensity as bone. but I mean, there's some like linear signal in there. I kind of maybe it's a chronic bursitis, maybe or
Yeah, this is really a chronic bursitis with, basically synovial thickening.
That's
Soft tissue here, but it's a chronic iliotibial band syndrome. Yes, John.
a lot of protein in the bursa, and there's a bursa right over that corner there.
Right. So this would be chronic bursitis.
This is a 45-year-old male with right lateral knee pain for several months with a creak and a movable mass at the lateral joint area during ambulation. So again, there's an arrow sign kind of pointing just deep to the IT band. I suspect it's probably, similar to last time, a little inflamed around, so maybe just like a bursitis.
Okay, but this one we have surgery and pathology for. So this is what that looks like when you go in and look at it on the arthroscope. And then take it out, this is what the histology looks like for a specimen. In this case, this is a chronic fibroma of the tendon sheath, and it's probably due to chronic long-standing trauma there, which gives you kind of a bursitis, and then that over time with persistent trauma becomes fibrotic. And sometimes with these cases with chronic inflammation at the insertion of the iliotibial band, you can get bony hibernation on the CT with thickening there from chronic disease, which can be positive on a bone scan. Here's what that looks like on an MR examination, where you can just see what looks like a chronic traction injury at the iliotibial band insertion. Up here. Okay. Robert.
All right, so we have a 49-year-old avid runner with bilateral knee pain and swelling. Just looking at the insertion of the IT band, it looks edematous. I think there's probably some partial tearing there, kind of on both sides. I think left greater than right.
And this is what it looks like. Here and here. This patient. And that's chronic iliotibial band traction injuries. Okay. Jason.
All right, this insertion of the IT band looks like it's partially torn with fluid.
Yeah. And bone edema
Yeah.
from traction injury. Good.
Looking at the IT band at the level of the femur, I mean, it's very regular, maybe some partial tearing. It looks, could be chronic too.
Yeah, so this is more proximal. And here, it looks like it's primarily a tendon injury rather than a bursitis or a traction change at the bone. So this is a more proximal chronic partial tear.
Is that all fluid in that area, John?
Well, I think you've got some fibrous tissues from the iliotibial band here that are markedly tendinotic and thickened here. Fluid within that due to the high-grade partial tear. And
what about the medial side?
The medial side, this is fluid in the suprapatellar pouch. And I think these are pretty normal tissues out here.
This patient has chronic medial knee pain. Right now I think we're looking at the insertion of the semimembranosus And those, oh, is that, would that just be like a semimembranosus bursal fluid?
What bursa is that?
Semimembranosus bursa?
Yeah, so pes anserine bursa here. And this is pes anserine. I believe this is a case that was sent to me soon after I moved to Santa Barbara back in the early 1990s. And they could palpate a mass here that was somewhat tender. And this was, I think, like a, well, no, this is not that case because he was a younger kid. And I think he was a physician's son back in Kentucky or something. And they were all concerned that it was a malignant lesion. So I was asked to look at it then in the very early days of MR. And this had that very characteristic appearance of the kind of a chronic fluid right in the pes anserine. So everybody was very relieved when we thought the diagnosis was pes anserine bursitis. They treated it clinically and it all went away.
All they had to do is stick a needle in there and make a diagnosis.
Yeah, actually, they drained it right after we made that diagnosis. They were afraid to stick a needle in it before because they were concerned if it was a malignant lesion, they didn't want to spread the disease. And if they were going to biopsy it, they were going to go to a cancer center. But when we determined it was probably a benign lesion, then they did stick a needle into it, got a little fluid out, but then treated it with anti-inflammatories, and it got completely better. Robert.
All right. Looks like there's a fluid collection kind of in that same region of the pes anserine. So be concerned about bursitis, some debris kind of.
Yeah.
Really.
Right. So this is just a much more fulminant case of fluid in the pes anserine bursa, the medial side of the knee here. So the pes anserine are really made up of the three tendons of the sartorius, gracilis, and semitendinosus, which comes around the posterior medial side of the knee and inserts on the medial aspect of the tibia. So this is kind of.
We used to use that insertion for rotatory instability on the medial side.
Okay.
We used to flip the case over and then suture it proximally next to the patellar tendon. We thought that by doing that, you could make the knee, the tibia go posteriorly on the medial side and eliminate the rotatory problem. That didn't turn out as well as we used to think.
Okay.
But that was a very common procedure.
Really?
Slocum procedure fell from Oregon.
Okay. So as far as the anatomy over here on the medial side, here's the semimembranosus muscle, the big muscle here. And I think we're going to talk more about the semimembranosus tendon. I don't know if we have or not, but I think we're going to talk more about it in a minute. And then there's the semitendinosus, gracilis, and the sartorius muscle here. And it's these two tendons and the tendon of this muscle that come down medially, posterior medially, and then attach on the medial side of the tibia, and these tendons make up the pes anserine tendons. So if you follow them distally, here we can see the two tendons posteriorly and the sartorius muscle anteriorly. Go farther down, we see the three tendons coming around the posterior medial aspect of the tibia. And then here we can see the three tendons coming down to their attachments on the medial side. Okay, and then the coronal plane, again, sartorius, semitendinosus, and gracilis. And then here we can see the three tendons coming down in the coronal plane and then attaching here medially. On the sagittal images, here's a semimembranosus tendon, which comes down here. And I think we've already talked about the 5, some people say 7 different attachments of the semimembranosus. And then if we go farther out medially, we can start seeing this, the pes anserine tendons coming down to attach on the medial side of the tibia. Yep, here's a semimembranosus insertion. So here it has 7 different insertions. It can insert on the medial collateral ligament, posterior oblique. There's an anterior arm. The direct arm is a primary one that we see, which attaches to the posterior aspect of the medial tibial plateau, just under the joint space. And then there's distal, and then there's also an attachment that goes to the popliteus muscle. And it explains how you can see the different attachment sites of the semimembranosus. Most of the time on the knee, we primarily just evaluate the direct attachment to the posterior aspect of the tibial plateau.
I think the meniscal part is probably the most important one
Okay. Why is that?
because it pulls the meniscus posterior out of the way when the knee is flexed.
Yeah. I think I'm going to talk about that in just a minute also.
Yeah, I'm sorry I jumped the
No,
gun here.
no, I'm glad you did that. No, there's I think I have a slide on that. Thank you, John, for reminding me. And it's coming up here. So this is called the posterior medial corner. So this muscle, this tendon with all of its different attachments are the primary stabilizer of the posterior medial corner of the knee. And then this is, I think, also what John was referring to. Here's the direct attachment coming down here. And it also attaches to the posterior aspect of the medial meniscus. It has a kind of a medial attachment, and then here it attaches to the fibrous band that makes up the capsule and the inferior attachment of the meniscotibial attachment. If that becomes torn, then what happens is that the posterior horn of the medial meniscus no longer will stabilize the knee, or the medial femoral condyle, and this is called breaking of the break-stop function of the knee, and this is often associated with an injury to the attachment of the semimembranosus attachment, which John was just talking about. When that tears and the posterior horn of the medial meniscus is no longer tethered here to the bone, then you get instability of the medial compartment. That's what you're referring to, John?
You get a posterior meniscus tear. That's one of the things
Okay, good.
we used to find
Nice. And here's just kind of a
at attachment.
good. And here it just
Sorry.
shows this web of different attachments of the semimembranosus coming down. All these together stabilize the posterior medial corner of the knee.
I also have a feeling that this is not present in all knees. This is more or less, maybe more common than not as common.
Okay. Yeah,
I don't think all these attachments exist
I think you're
in
probably right.
everybody.
I think you're probably right. Okay, let's see. Who's next?
Yeah.
You?
Yeah.
Okay.
All right. Medial pain 2 weeks after fall running. There's a high-grade partial tear of the semimembranosus.
Okay. So here's the direct attachment of the semimembranosus coming down to the tibia in this location. You can see that there's a partial tear longitudinal. You can also see there's some edema here more distally, probably in the area of the pes anserine bursa and through here. And I'll see some other changes here. But this is, and as John was referring to, here's a tear of the posterior horn of the medial meniscus. Even though this patient had a negative arthroscopy, we can see that there's a lot of injury to that semimembranosus attachment here, the posterior aspect of the tibia. Oh, I think this is the same patient we saw before. We're just looking at a different area.
Okay, so looking.
Usually it's more than one injury.
Yeah.
Yeah, looking at the medial tendons on the image on the left, I'm seeing edema surrounding that muscle. Is that the semitendinosus or the
So here probably the pes anserine's coming down here.
Mhm.
Two of them. I'm not sure we see the third one. And then and here's where that big semimembranosus should attach.
Mhm.
And then if we go more medially here,
Oh.
we see that there's something torn and retracted here.
Okay. That's a semimembranosus.
Yeah, so this is a tear of the semimembranosus. Obviously, all of its attachments tore here, which allowed it to retract proximally into the thigh. Okay.
This is a 33-year-old MLB All-Star with knee pain after an outfield play. And it looks like along that medial side, we've got a bunch of edema. So probably a tear of the MCL and probably the that
So the case
Yeah,
I
MCL.
up high and follow the pes anserine tendons down. So here are the three tendons of the pes anserine right here. And you go more distally, and as we go farther down, what's happening here?
We're kind of losing, the definition of those tendons. So we're getting a bunch of edema and thickening of those tendons. So probably a tear of all three distal tendons.
You can't follow any of the three all the way down to their attachment. And here distally, we can see that there's a lot of hemorrhage and edema through here. And this was a rupture of the three tendons with retraction. Robert.
All right. Let's see a whole lot here. There's maybe a joint effusion. Maybe some edema.
Actually, I think this is okay. So posteriorly, we can see there's a marker here. What's that marker overlying?
That's semitendinosus.
Good. This is the tendinosus. This is the semimembranosus. The tendon of the semitendinosus comes off its muscle much higher up than the membranosus. So when you get around the knee, you see the tendon of the tendinosus where we can see the muscle of the membranosus. And then there, this is where the symptoms were. Here's the T2. Here's the PD fat sat.
Yeah, it looks like there's pretty extensive edema surrounding the semitendinosus tendon.
And if we go farther down, this is what it looks like.
Yeah, there's even more edema, so it's probably torn.
And we don't really see it back here. That may be one of the tendons, but back here, we don't see the semitendinosus anymore. And we can't really follow it all the way down to where it attaches. And this was a complete tear of the semitendinosus tendon. Another angel player from many years ago. Okay.
That has a long tendon. Not like sartorius. Sartorius is rather short in terms of a tendon.
Thanks, John.
So the tendon, it's semitendinosus gets pulled quite a bit often. And semimembranosus is the one that's the most, I think.
Okay.
I don't know what your experience is, John, probably.
Yes.
Same.
Yep.
So I think we're in the pes anserine bursa with a lot of low signal structures. I'm not sure if that's, debris or tendon just based on this. I guess yeah, yeah, okay.
So anytime you have a real bursa, you can get synovial chondroma if you metaplasia, and this is synovial chondromatosis of the pes anserine bursa. Something you see every day.
Okay, so we're looking at the medial side of the knee there, some edema along the medial femoral condyle. I think, let's see. Yeah, there's an avulsed fracture fragment at the.
Okay. So then the big question is what attaches there?
I think this is the adductor magnus.
It's the adductor magnus.
Yeah.
Attaches right there. And we can see there's a little avulsed fragment there.
Yeah.
The adductor magnus avulsion.
What would anybody do for that?
Oh, the treatment, I think it would be conservative. I think
No, I'm talking to Robert.
Right.
Oh.
This is Elior's case.
I'm sorry. Anyway, usually you put it in a cast.
Thanks, John. So conservative.
Yep.
It's a 14-year-old female who's a professional sport climber with knee pain for 2 years and pain in her hip during flexion. And it looks like similar to last case, we have an avulsion of that medial femoral condyle at the adductor magnus insertion.
Now here's the CT. Here's the MR.
Not non-union.
Yes, I was going to say that, a non-union.
Okay. And here's another one, another patient where you can see the typical location of the avulsed bone fragment.
But you notice that this again proves the fact that kids break bones, they don't tear tendons.
Yeah. Okay, and this just shows where the adductor magnus and the adductor come down. They attach to the shaft of the femur, and then there's this component that comes down to the medial, posterior medial aspect of the distal femoral condyle there on the medial side. Just shows the attachment sites of the different components there. Robert.
All right, so we have an 11-year-old with a soccer injury, and it looks like there's a fracture to the distal metaphysis of the femur that extends into the physis and the salter hairs too.
Okay. And here we can see some of the injury to the growth plate across there. That's the patient, kind of normal. And then here we can see the patient. This is a PD. This is a T2 through that growth plate. What's this back here?
Good question. Looks like it's intermediate signal.
It looks like a big mushroom back there.
Maybe a hematoma, maybe?
Maybe a nuclear explosion here from the cortex. Okay, here's some more images.
Is that like a subperiosteal hemorrhage?
So here's your fracture coming down, goes across here, and what's happening here? One of the things you commonly get in kids with fractures are subperiosteal hematomas. So you can see there's instability here. There's actually a displacement at the fracture. So this fracture is displaced by about 5 millimeters, which is very important to describe. And this is a displacement of the bone here. And you got subperiosteal hematoma with probably a little tear in the periosteum, which is allowing hemorrhage to extend into the soft tissues there. Okay. The other end of the spectrum.
Skiing. So, looks like we have a full thickness tear, medial head gastrocnemius.
Okay. Yeah, and we're talking about that posterior medial corner, and then there you can see the gastrocnemius avulsion.
Okay, rule out gastroc tear. Okay, I think, yeah, we're looking at the medial gastroc. Seeing some edema there. Oh,
This
that's
is
the medial.
lateral, this is medial.
Okay, so lateral gastroc.
Maybe there's some here, maybe both.
Yeah.
Okay.
So, I mean, just edema. Okay. Are we looking at the popliteal vein?
Okay, deep vein swelling, real like gastroc tear. See
Okay.
a lot of edema here.
Oh, I see.
Medial. We see a lot of edema around the lateral side.
Yeah. Yeah. So we have a
What's
DVT.
this thing here?
Yeah. Occlusion of the popliteal vein.
So don't forget deep vein thrombosis. That can also produce a lot of edema. Okay. Okay, so let's talk a little bit now about the extensor mechanism. Go to the other side. We'll talk a little bit about plica, quadriceps tendon, lateral pressure syndrome, retinacular tears, patellar tendon, patellar injury, prepatellar bursitis, and infrapatellar bursitis, among other things. So one of the things that we've talked a little bit about before that you can see are medial plica, and they can become thickened. They extend into the joint. They may be symptomatic. They tend to, these medial plica tend to be common. They tend to extend inferiorly into Hoffa's fat pad. These were a big issue in the early days of MR because plica were commonly, as John's already described, talked about in surgery. Surgeons would go in and lyse these and convert what would have been a diagnostic arthroscopy into therapeutic arthroscopy, which significantly changed the monetary reimbursement in those. Then we found that they were see them all the time by MR. The ones that became symptomatic were actually quite rare and tended to become more edematous, as I'll show in a minute, and extend into the joint space where they can be traumatized between the patella and the trochlea in this location. So this would be a medial plica. This is one I'd comment on the body of the report. It's a little bit thickened. So that's a medial plica. You can often see these nicely in the sagittal images, the plica extending here, and notice how they can extend down and into the fat within Hoffa's fat pad. And some people believe these may be symptomatic on Hoffa's fat pad. The bottom line is these, if they're not edematous, like I'll show in a minute, they tend to be asymptomatic and not really not much. So that's a thickened medial plica going into Hoffa's fat pad. This is one that I would describe in the body of the report. Okay, now the other thing that these can do is they can become thickened if they're in next to the bone. They can rub against the bone and actually produce chondromalacia of the medial facet of the patella. In this case, we can see a little subchondral osteophyte here also adjacent to this medial plica, kind of an osteochondral reaction. Not common. Again, here's a typical medial plica, kind of extending into Hoffa's fat pad. On the sagittal images, we can again see it here. Or again, you can see where it could rub the cartilage here, but these are common and they're rarely symptomatic. So I like to see this just arthroscopically shows it coming down here next to the cartilage, which looks okay. Medial plica. See who's next?
I am.
Okay.
All right. So we have an axilla here, and it looks like the medial plica is maybe a little thickened. Yeah, right there. So
5/17/07. Now this is 10 months later.
So significantly more thickened medial plica with a larger effusion.
The patient had trauma right before this. If you notice, the patient now has an ACL graft. But notice how thickened it is.
Usually the plicas don't appear unless there's trauma. And so And the treatment for most plicas is immobilization in a shoulder cast or splint. In this situation, that is pinching the patella. This would need surgery, and it is from chronic injury. So you'd have to remove that. And there's a no consensus as to how much you remove that I know of. So if you take too much, you might have more scar formation, or if you take it too little, you'll have a recurrence. So it's probably a little better to take more than less.
Thanks, John. Robert.
All right, so here we have a small joint effusion, and it looks like there's thickening of that medial plica.
Yeah, so here we can see a thickened medial plica. The cartilage next to it looks normal, but this is one I would certainly comment on. And but yeah, some days I might put this in the impression. Most days I wouldn't. Okay, Jason.
All right, so there is joint effusion with a thickened medial plica, which is perched over the medial trochlea, and there seems to be chondromalacia with marginal osteophyte.
Yes. Yeah. Once I start seeing what I think might be chondromalacia associated with it, then I up it into the impression of the study. And here you can see that there's a lot of scarring and probably some chondromalacia here, which may be associated with the plica. And that this patient was thought to have typical medial plica syndrome. They actually did arthroscopy and lifed the plica in this particular case. I don't remember if they did any chondral surgery here. We'll talk about chondral surgery in a lecture later in the year when we talk about articular cartilage.
Okay, in the suprapatellar.
Wait a second, let me just see for a second. Okay, go ahead.
In the suprapatellar joint space, there's this structure that is the same, mostly same signal intensity as fat. I mean, could this be a plica as well? But I mean, just a
Here
different
is an
appearance of
accurate
it.
image. So we see a little something here on the medial side. We follow it out. There it is. Follow it up. There it is.
Mm.
There it is. There it is.
Yeah, so okay, so it doesn't saturate, there's no fat saturation.
Right.
So could this be an edematous plica?
Yeah, this patient had trauma and they removed this and it was hemorrhagic.
Okay.
So it produced hemorrhage into the plica, which thickened it and made it symptomatic.
Okay.
That's something I've never seen, except at your lecture, John. The placas don't bleed much, but it's scar tissue.
So here we're in the suprapatellar joint space. And I mean, besides the fusion, I would say that might be the superior plica then, mildly thickened, or yeah.
Robert, what do you think of this case? The T2 weighted image.
Looks like there's simple fluid superiorly, and then this kind of intermediate signal, lobular stuff.
Okay.
What does that mean? It's intermediate signal. What? There's a white signal above there. That's fat, right? Well, whatever.
No, that's
Right.
fluid.
I'm sorry, it's fluid. But when you see something like that, what do you think of?
I mean, I would think of other things like maybe blood or
Something proteinaceous,
Yeah.
which is blood. No.
Yeah, so here we can see actually there's a complete plica here, some extension of the suprapatellar pouch above it, and that there was some hemorrhage in here. This is from Brazil. Here's another complete superior plica with a big fluid collection here, which actually had some mass effect associated with it. So on 4/21/2008. We'll talk about that classification. And then they aspirated it and put in steroids, and this is what it looked like 10 months after they aspirated and put in steroids. So this was, now there is a Zendoric classification of these, whereas if you have a complete septum, it's called grade 4 or complete septum, the way most of them are incomplete septum and the suprapatellar pouch. I've never used this classification, and I've not really heard of it except in the literature. You just rarely can have complete septum in the suprapatellar pouch where you have two different pouches.
All right, 15-year-old basketball player pain with jumping. I think the patellar tendon is very hard to discern, and there's
Actually, let's stop here. This is a good stopping place. We'll start this case on Monday. Okay?
okay, sounds good.
Any questions?
So all those images that you were showing us,